So if you've just finished with the section of the lecture before this, you'll recognize this slide. This is the one we ended on. So we're talking about subcutaneous injection sites, and the most likely are the first two that you see here. Once again, the posterior upper arm for adults and the anterolateral, it says thigh muscle, but it's the fatty tissue over the thigh muscle, so don't get distracted by that. The fatty tissue over the anterolateral thigh muscle on infants. So getting more specific, birth to 12 months, we're looking at that lower left picture. Of course, that is not an infant, that is an adult, but the idea is that that's the general location. So it's the fatty tissue over the anterolateral thigh muscle. When you're giving immunizations to infants, that's like the one you really want, because to be honest with you, if you have a compliant parent, even with a fussy child, it's not that hard to hold the baby and to have the mother hold the leg or you hold the leg. There's various techniques for it. When you learn this in clinic, pay attention to how different MAs do it. One tip I did learn early on in my career with children, I've immunized a lot of babies. And one of the tricks I did learn is to feed the child during the immunization process. So if mom's breastfeeding, you just give them a moment alone to get set up and get the baby in position and get the baby nursing. And then you can deliver an immunization pretty easily. If they're bottle fed, same thing. Just give the parents time to prepare whatever they need to do and get the child nursing. It's amazing that if you take a baby and try to hold that leg and they're being fussy and don't want to be in that place and they don't have a distraction, they will fight you and they will fight you and they will fight you. But the amazing thing is, if they're being fed, they'll focus on the food. And I've had situations like that where I've given multiple injections and the child never even noticed it, or at least did not react. So I'm not telling you to do this as official advice. Once again, this is specific to your sites. Some sites do not want you to do that, and they will specifically say, do not do that practice. So I'm not telling you it's something you should do. I'm suggesting it as a possible technique. Once again, check with your sites, know what their expectations are, don't make assumptions. For anyone else 12 months and older, the fat tissue over the anterolateral thigh can work, or the fatty tissue over the triceps. I'd say maybe you can get by with that thigh muscle maybe up until 5 or 6 years of age with some kids not even that far. Subqs in the arm on anyone younger than that can be tricky, so you definitely want to make sure you have the right angle on it. And definitely once they're over, let's say 10 or so, that posterior upper arm is pretty easy to work with. On very thin patients, of course, you want to use a short needle and increase the angle a little bit. We'll talk all about that when we get to the lab portion next week in class. Insulin and heparin, once again, chances of you administering these are not strong, but that may happen. It happens in the abdomen, and this is about absorption, so we want to make sure, because there's more fat there, it's going to absorb even less quickly. The medication is going to be a little bit diffuse throughout the tissue, and then it's going to absorb very quickly after that. So it's going to spread and then get into the bloodstream. So as we said earlier, insulin absorbs quicker than other things in fat, but it still is a kind of a slow process. You want to stay away from the umbilicus, so at least a 2-inch perimeter around the umbilicus, you want to stay outside of that. As it says here, insulin is absorbed faster when it's injected into the abdomen. And that's because it disperses over that large area, and as it moves down into the muscle tissue, it begins moving into the digestive tract via the vasculature under the subq layer, not within it, but under it, and thereby absorbs pretty quickly once that process gets started. But the initial onset is slow as it spreads throughout the area. For injections that have to happen recurrently, and that, once again, insulin and blood thinners are the most likely ones. Or if you're doing, I have seen doctors order as many as 5 or 6 immunizations on one child in a day. The parents agree to it. You're going to want to rotate those injection sites. You can't keep going to the same area. So you want to keep, rotating around the body. Each injection site should be at least 1 inch from the last one. And, you could cause some scarring. What you're more likely to cause is a lot of discomfort and pain and swelling in the area if you try to give too many injections or too much fluid and a subq route in one area. So you're going to want to, kind of branch that out. If you are doing these as chronic injections like insulin, once again, blood thinners, those types of situations, if you fail to rotate the sites, it can lead to scarring and hardening of fatty tissue. And that's going to happen over a long time. So that's nothing I would worry about in immunizations. But with long-term administration of certain drugs that are going to be used every day or multiple times a day in the subq tissue, you may want to have a plan for rotating those, or instruct your patient on how to rotate those different routes so that they're not, hitting the same tissue every day. Some more assessment, important considerations. You want to know if they have any allergies to medications. That should happen when you reconcile the medication list. The doctor should be asking them that. It's not a bad idea to ask it a third time right before you give someone any type of shot. It says be sure that the drug is non-irritating. The only way it could really be irritating would be if there's an allergy to it. So that's kind of covered in the first level. Some medications are just irritants to the skin and to the tissue, and no matter what you do, it's still going to be an unpleasant experience for a few minutes or maybe a few hours after it's administered. There are some travel immunizations. I know people have told me that they had, irritated tissue for a day or two afterwards. Most things they're going to survive. What we're really worried about are two types of reactions. If it's going to be a systemic mild reaction, and that might result in some very mild asthma and welts appearing on their body. And the one we're really looking for is anaphylaxis. That's the life-threatening one where the throat can swell shut and it could be dangerous. Those we want to be very aware of. If a patient has any reactions anaphylactic, or if they've ever had something called Guillain-Barré, and it's a French word, so don't ask me to spell it, but Guillain-Barré is also a very rare type of paralysis that's associated with certain types of immunizations. The flu shot is one of those that people are at risk for. We give hundreds of millions of flu shots a year, and there's maybe a couple dozens of cases of Guillain-Barré that pop up. So it's not super common, but it's out there. Also know that you're not going to give any more than 2 milliliters or 2 cc's in a subq injection. And a lot of these ones, like when we talked about the live vaccines, so the live attenuated vaccines, they must be kept in a refrigerator with a controlled temperature range. One of the jobs of the MAs would be to check those temperatures every day. You want to separate those sites, once again, by a minimum of 1 inch when you're doing multiple injections. You rotate the sites. Avoid injecting into hard, inflamed, red, and burned. Any tissue that doesn't look healthy, you should not be sticking a needle into. But let's sum it up and say that. If that skin doesn't look good right there, it's probably not a good site. Which prompts the question, tattoos. So when I first started working, it was always, the rule was you never did an injection through a tattoo. That changed over time to, it doesn't really matter if you go through the tattoo or not. Sometimes you may have to, especially if you're giving a flu shot and they have tattoos on both deltoids and they have tattoos on the gluteus maximus, the upper region. Well, if they've selected to tap themselves in such a way, you may not be able to get around it. But I've had to go right through people's tattoos before. It's, once again, facility specific, so understand what standard you're being held to. But if you need to and you have permission from your doctor, you can go that route. Once again, strong consideration and making sure you're following the rules of the facility. Once again, don't massage areas after you do injections. I know you'll see this with IM injections sometimes, and probably less of an issue there. Definitely with subq. I know it hurts a little bit. It's a little bit of an owie, but the patient will survive it. They might be uncomfortable for a few moments, but they'll survive it, and rubbing it could actually make things go the wrong direction. So just leave it alone. If a patient says, well, I bruise really easily when this happens, I get hematomas, have some ice on hand, and they could put ice over it for a few minutes after the injection. And the reason for another thing that you have to consider there is you're going to ask them to stay for a few minutes after they have an injection. You're not going to send them right out the door. So while they're sitting there, they can ice the injection site and probably offer some comfort. And it makes it look like you really care about how they feel, which, of course, at the end of the day, we really do. When you want to seek additional help, well, if that injection site does not stop bleeding, if there's an extraordinary amount of pain, and some patients will fool you, they'll you think they're dying, and then within a minute or so, they're perfectly fine again, but there'll be that very intense moment. However, if there's a lot of prolonged pain and it's going on and it's not resolving within 30 seconds or a minute, you probably should call a doc in or get some advice from a supervisor. If you should happen to put a medication in via the wrong route, put a subq in IM or an IM medication subq, you definitely want to let someone know, because you're going to have to chart that, and that's going to get into a whole medical legal aspect. So my best advice for that is don't do it. If it should happen, report it to your superior immediately. Do not let the patient go until they have been cleared by a physician or by the supervisor. Once again, site specific, so check with your facility. But you would never want to give a medication by the wrong route and then let the patient go without letting anyone know. That would be a strong infraction of your code to protect patients. If a rash develops quickly around the injection site, so you might have them wait 10 to 15 minutes after an injection to make sure there's no reaction. If a rash pops up at that amount of time around that site, you may want to have a doctor take a look because there may be a stronger reaction just about to happen. If they develop a fever within a few moments of an injection, you definitely want to let a doctor know. And if there's any signs of allergic drug reaction, you definitely want to, you want to get help on that one. So if there's any difficulty breathing, rashes popping up immediately on the skin, irritation, if people become agitated, disoriented, any of these things that appear to be abnormal, other than just complaining about the pain of the shot, you may want to have them assessed to make sure they're not having a reaction. And some allergic drug reactions, so I mentioned earlier that you can have a mild reaction, and that's the most common one. And what usually happens is they will get welts on the skin, and that may last for several weeks before it goes away completely, or sometimes a rash will develop. These are considered mild reactions. There might be a little bit of asthma-type reaction for a few moments, but it shouldn't last too long. Anaphylaxis is the other side of that coin. This is a severe allergic reaction that occurs suddenly and immediately. So it's a serious condition requiring immediate medical treatment, and it can be deadly. So I don't want to fool you on that one. And this is why we usually ask patients to wait 10 or 15 minutes after they get an injection. Anaphylaxis typically will set in within 5 minutes. If you have them there for 15, it's very unlikely to happen. I did once, very late at night, gave an immunization, and my doctor told me to release the patient, and I did, and they had an anaphylactic reaction in the parking lot and made it back to the front door of the clinic and were able to bang on the door and open it. That was the last time I did that. If a doctor gave me an order to release the patient right away and I can go home for the evening, I'd say, you know what, I'm just going to sit here for a few minutes and do some paperwork and just let him have a seat. As long as the doctor's okay with that, that's fine. Long story short, you want to really monitor your patient and make sure anaphylaxis is not set in. So anaphylaxis, you're going to have pruritus, so it's itching. Urticaria, that's our official word for hives. Dyspnea, which is difficulty in breathing. Dysphagia, so they won't be able to swallow. You'll see them get pale and get sweaty. They're diaphoretic, that means shock. A weak and thready pulse, convulsions. LOC, meaning loss of consciousness, and of course death. We don't even want to go there. We don't want that to ever even come close to that. So you have a long list of things that are going to happen before that death part happens. Recognize these. Within a few minutes, if they start have itching, if you start seeing hives come up, all of a sudden they go, I'm having a hard time breathing here. These are all reasons to seek a higher level of medical care than we can deliver. So we want to let a doctor, a supervisor, a nurse practitioner, PA, someone know that so that we know that patient's going to be safe. Your role, so we're going to have patients remain 10 to 15 minutes after they get injections. We're going to monitor, as I just said, and I made a lot of emphasis, so I won't go over it again. We want to make sure we know where the epinephrine is stored. It might be in the form of an EpiPen like you see here, and this is the automatic injector, and that's really great if you have one of those. A lot of sites will just have a vial of epinephrine and a syringe with a needle attached to the side of it, all in sterile shape. And so if it happens, they can open that up, they can put the needle on, drop the epinephrine, and give the injection. So EpiPen is going to be the easiest, but however you can get that patient epinephrine, keep in mind, generally a doctor is going to administer this. Administration of an EpiPen injection is immediate after anaphylactic if you want it to work. And you're seeing a very classic route of administration right here. When the patient stabilizes, administer an injection of antihistamine and ensure that the emergency crash carts are stocked and that supplies have not expired. So we haven't gotten into crash carts. You may or may not know what they are. Once again, by this level, unless there's no doctor present in the building, at which point you shouldn't have given the injection anyway because you need them present and you need them to give the order. In the absence of no other medical help, you may have to administer epinephrine, but it shouldn't be the first place you go. Once again, site-specific, know what your supervisor expects. That's everything for subq injections. We'll see you in lab on Monday. We'll get started doing our own subqs, and we'll teach you some really fun stuff. Hope you have a great weekend, and take care, everyone.